Okay, good evening. Welcome to the weekly research seminar at the Center for Institutional Studies at the HIC University in Moscow. We are very pleased to welcome as our speaker tonight, Armenak Antinyan. I hope I didn't mispronounce Armenak's last name. Armenak is a professor of Wenlan School of Business at Zhongnan University of Economics and Law, which is in Wuhan, China. And I think I've heard about that city recently. Armenak's degrees are from the University of Venice, from Sorbonne, and from Yerevan State. He does behavioral and experimental economics. And today's presentation is on cancer screening invitations in the developing world. I would like to remind everyone to please register yourself in the chat column of this Zoom seminar. And now, Armenak, the floor is yours. Thanks very much.
Okay, thank you very much for the introduction. Just a very short question. Do you ask questions during the talk or in the end, and in which format do you ask the questions, just to make sure I'm attending?
It's up to you, whichever you prefer. If you would like to be interrupted, then of course, people would be welcome.
Interrupt me at any point in time, no problem at all from my side. It's fine for me.
And it would be good if you can please keep an eye on the chat column as well, because some people might be asking questions in the chat.
Okay,
other than just raising their hands. Okay, all right, thanks.
Okay, fine, no problem at all. So this is a joint work with two colleagues of mine, Luca Corazzini from University of Venice and Marco Bertoni from University of Padova. In a nutshell, this is collaboration between the academic authors of us and the Ministry of Health of the Republic of Armenia and United Nations Development Program in Armenia. So basically, there was a policy problem in Armenia, and we have a cervical cancer screening program, and we have low participation in this program. And basically, we joined our efforts with our UNDP and government colleagues to kind of try to increase the uptake of this program. Okay, in a nutshell, the scientific contribution of this paper is that, to the best of our knowledge, this is one of the first randomized controlled trials in the developing world that studies the impact of invitation letters and reminders on cervical cancer screening participation in general. So this paper is now in the second round of the revision in social science and medicine. We are actively working to resubmit it in the next few days. Okay. So, what is the motivation? Why do we do this? And why is it important in our view? So in general, there is quite frightening statistics about cervical cancer. In general, this is the fourth most frequent cancer among women in the world. And the biggest problem of this cancer is that around the vast majority of deaths and incidence happens mainly in low and middle income countries. So, there are two reasons why this happens. The first reason is that, in general, organized screening programs in low and middle income countries are generally absent. So they don't exist because they are costly, they require a lot of organizational effort from, for instance, the Ministry of Health and the government. That does not always take place. And the second reason is that even if there are such programs, for instance, one program we have in Armenia, there is quite low participation in this kind of programs. Okay, so for instance, in Armenia, the participation rate is around 28% of the eligible population in 3 years, which is well below the threshold of the government, which is around 35%. So, and what we have seen actually is that in the last 40 years, there is really sharp decline in cervical cancer incidence and mortality in high-income countries. And actually, this is mainly attributed to the fact that there are organized screening programs in developed countries, and people actively participate in these screening programs. And as a result, we see dramatic decline and in the mortality and incidence, and basically improved statistics in these countries. So this is basically the map that shows that the problems in Africa are quite, the darker the blue line, area is, the worse the situation is. And we can see that There are some problems in Latin America and in the South American continent. We see basically the Africa is not doing well. Armenia is somewhere here, so again the situation is not one of the best, and also we see some problems in Russia. And the Western world and the US and Canada are doing, it seems, quite well with respect to cervical cancer statistics. So far I was telling only bad news, but there is also good news about cervical cancer. And the good news is that this is one of the most preventable diseases among all cancers that we can have. It takes quite a lot of time for the cancer to evolve, and if the cancer is detected in early days or early weeks or months of development, then there is a very high likelihood that the patient can be treated and saved. So the longer it takes, the worse it becomes. So there are a few main prevention devices, and those are suggested by the European Commission. One is the HPV vaccination of girls aged 12 and higher. So this is not really universally accepted in many countries. For instance, in Armenia, there is really a big opposition toward HPV vaccination, and this is not only, and the opposition is not only from the general population, but also there are some doctors, surprisingly, that oppose to HPV vaccination, okay? So the second one is population-based screenings for women, for instance, from 25 to 64 or in some age range. Every 3 years, for instance. And the third one is HPV testing. So in Armenia at the moment, we have this second approach, population-based pap tests of women aged 25, of 30 to 60. I'll tell you the eligible population in few slides. So every 3 years. So there is this organized screening program that is being run starting from 2015. But basically, what is the problem? So what happens in low and middle income countries? So as I said, the first issue is that there is lack of infrastructure and healthcare resources to implement this kind of screening activities. And why the participation, and if in the second bullet, even if there is this organized screening program, the participation is very low. So one of the reasons is that in general, there are a lot of information gaps. So the population, for instance, does not know what are the benefits of cervical or of cancer screening in general, and for instance, cervical cancer in particular. There might be some cultural issues, and there are also like socio-economic barriers. Like, for instance, one cultural issue is that since cervical cancer is sexually transmitted, for instance, females in developing countries, especially in rural areas, may be ashamed, for instance, to go to cervical cancer programs, or for instance, their husbands may not really allow them to go. And there are some sort of cultural issues with this. And the socioeconomic barriers are that, for instance, females may not really have resources to go to the hospital, so far, so forth. So scientific research has already illustrated that in high-income countries, if you're sending invitation letters and reminders, those invitation strategies are stimulating participation in the cervical cancer screening program, okay? And there is also evidence, this is a paper by Luca and Marco in Italy, about breast cancer screening program in Sicily. If you're not only sending invitation letters, but you are framing the invitation letters, in other words, you're changing the content of the invitation letters, for instance, following some guidelines from behavioral economics, you might be able to boost the participation even further, okay? So at this point, we don't really have research, or we have lack of about invitation letter and reminders sent to eligible population in developing countries with regards to cancer screening, okay? In other words, we don't know if you are sending a letter or a reminder to an eligible female in a developing country, for instance, in a rural area, is she going to react to the letter and is she going to visit the practitioner or not? And also, we don't really know whether different frames are working differently in the context of developing countries, okay? So those are basically the questions that we are trying to understand with this project, as I said in the very beginning. And you may ask, okay, so we have information about developed countries, so we know that invitation letters and reminders are working in developed countries. Why should, for instance, the overall framework be different in developing countries? In other words, why do you suspect that if you are sending letters and reminders in developing countries, the eligible population may react differently, okay? So in general, there are several reasons that we think are important, and for these reasons, it may be the case that invitation letters and reminders affect females in developing countries differently. One is, for instance, the absence of insurance and low income. In general, in developing countries, Armenia is not a big exception. There's not really a developed insurance system, and most of the payments by females are done out of the pocket, okay? Or by households are done out of the pocket. So for instance, a household, a female may be really afraid, for instance, to go to a screening because she might kind of suspect that, okay, something can be discovered. And if something is discovered, then perhaps she has to make some out-of-pocket payments. So this might be one problem. I have already discussed that cultural traditional values might be a problem, since, for instance, cervical cancer is transmitted through sexual intercourse. Then there is also a big distrust toward the medical system in general, for instance, in Armenia, because of corruption in general, and also the doctors may not really have the highest quality. So someone may suspect that, okay, if you are going to a medical examination, then the doctor may kind of not really treat you well if something serious is discovered, or alternatively, the doctor may artificially create a problem for you in order to take money from you and treat you in some way. So in other words, there is a distrust that the doctor may give you a treatment if you don't need it. And this is a reason that, at least in Armenia, shies away a lot of individuals from screening, okay? And these kind of reasons allow us to think that the response to screening programs and invitation strategies can be different between high-income countries and low and middle-income countries. Okay, so this is the main rationale behind doing this stuff. Do you have questions so far, or should I go forward? Okay.
So far, so good, I think. So please, no questions.
So since I think many Russian colleagues and friends know about Armenia in general, but just to give a very brief introduction where Armenia is and well, what is the country context. So Armenia is here on the map in the South Caucasus, and with a population of, it's a post-communist middle-income country. Still, we have a lot of problems because we are a transitional country trying to kind of recover from the USSR and going toward capitalism. We have around 3 million population with a GDP per capita of around $4,000 US. And actually the poverty rate is quite high, especially in the region where we work. Around 45% of the population is below the national poverty line. So with regards to cervical cancer incidence, we see that in Armenia, the incidence, this is the incidence rate per 100,000 population. So we see that in Armenia, the incidence is kind of lower than in European countries. One of the reasons is that basically Armenian women do not really go to screening that much. And given this, not always cervical cancer is discovered. And what we actually see, which is quite alarming, is that in terms of mortality rate, the mortality rate in Armenia is around 1.5 times higher than, for instance, in European countries. And this is because, first of all, as I said, medical treatments are not always of the highest quality. And the second reason is that since Armenian women do not really go to screening quite often, sometimes the cervical cancer is discovered at the very latest stages of development, which makes it very hard to find a treatment for this disease, which results in higher mortality. Okay, so those are basically the main statistics of Armenia compared to European countries. So about the cervical cancer screening treatment in Armenia. Okay, so before up to 2014, so the screening was opportunistic in the sense that if you were kind of suspecting that you have problems, you would just go to a general practitioner and this guy would send you to conduct a pap test, okay? And you would pay, for instance, out of your pocket. So since 2015, World Bank in Armenia was running a big project called Disease Prevention and Control Project. And within this project, several national screening programs were implemented. Okay, so I'm not really sure. I don't really know how expensive, this should be, but as far as I remember, because we're having some discussions with our colleagues at the ministry, is around 10 to 15 euros, if I'm not wrong. And especially in the rural areas, this can be quite a bit of money because the average salary is around 200 euros, I would say. So, I mean, ideally it would be quite, for a rural household, for instance, or for a poor household, this would be a substantial amount of money. And since 2015, and also take into account that if someone wants to do a PAP test, then especially in rural areas, there are not always hospitals in the villages. So there is some traveling from for instance, from your village to a nearby village, or from a village to the city center, to the center of the region to do the test where most of the hospitals are. So this is also something that comes in addition to the money that you have to pay. So since 2015, World Bank, as I said, was running this disease prevention and control project in Armenia. And within this big project, there were several several screening programs that were initiated. And the screening program, the cervical cancer screening program that we are working in, was one of those screening programs in general in Armenia. Okay. So according to the rules of this screening program, there is one free screening every 3 years, and the eligible population of women, which are the women from 30 to 60 years old, they can go to their to the primary healthcare unit they're affiliated with, and they can undertake the test. Okay. So before our intervention, we intervened in February 19, 2018. So before our intervention, there was no invitation system officially introduced in Armenia. So what the government was doing, they are basically using some classical advocacy tools. For instance, there were some radio programs about cancer screening, cervical cancer screening. There were, for instance, leaflets that were distributed in the supermarkets. So leaflets were distributed, for instance, in the elevators in the buildings. Some brochures were put in different places, so that, and the hope was that this would capture the attention of females, and this would trigger screening participation. Actually, what we tried to do, we tried to introduce this invitation system and check whether, for instance, females would react to this invitation system and what kind of and also we tried to manipulate different strategies of invitations to see basically which one works the best. Okay. And we intervened because as of February 19, 2018, the participation for the government was not that satisfactory. Okay, so that's why they were asked to work with them. So the region where we work, we did this experiment in a specific region in Armenia. So this was not an Armenia-wide experiment. So please, once I have 10 minutes left, just let me know so I know how to proceed. So this was not a wide experiment. This experiment was done in the region of Shirak, which is the poorest region in the Republic of Armenia. As I said, around 44% of the population is below the national poverty line. For those colleagues who remember USSR, then basically there was an earthquake in the region of Shirak in 1918, one of the biggest earthquakes, and basically this ruined the entire industry of the region, which was one of the most prosperous regions in Armenia, and that's why currently this is one of the poorest regions in the country. So the population is around 250,000, and this basically you can already see what is the urban-rural divide. So I'm not going to tell the numbers once more loudly. So, and we decided to do this, to implement this randomized controlled trial in Shirak for twofold reasons. First, the screening participation in this region was the lowest among all the regions in Armenia. That's why the government specifically asked us to work in this region. And the second reason is that since this is one of the poorest regions and most of the payments to hospitals or to primary care units are out of the pocket, if something is detected at a later stage, this is already a big burden for the females. Because basically they have to pay a lot of money for the treatment. That's why we thought that, okay, if we manage to help them discover something in the very early stages, then perhaps the treatment is going to be much cheaper and this will be a much less burden for them, which would somehow result in some achievement of some development goals also for the UN. Okay, so what we do in the trial in a nutshell. So first of all, we manipulate the presence of an invitation letter. we manipulate the presence of a reminder on top of an invitation letter, because there is a huge literature in behavioral economics arguing that reminders are in general more effective than, for instance, just letters themselves. And also what we do, we manipulate the frame of the invitation letter. More specifically, we are using positively framed and negatively framed invitation letters. I will tell you in the next slide what this positive and negative framing is. And also we are kind of working with the so-called concern for others, or other regarding, or social preference frame, which is again another big stand of research in behavioral economics. In general, we have 8 different treatments. Each treatment is a different invitation strategy that I'm going to detail. And we have one control treatment where the individuals do not receive any invitation, and all our treatments are basically compared to this control treatment with no invitation, okay? So when I speak about frames, first of all, the letters are all similar, but the frame, okay? So the neutrally framed letter basically invites the female to a specific slot. For instance, it says, please come from March 3 to March 10 for a screening in your primary healthcare unit. Please go to your doctor, general practitioner. And on top of this, it provides additional information. And this neutrally framed information states the following: please know that scientific studies demonstrate that participating in cervical cancer programs can have relevant positive effects on the treatment of an early diagnosed disease. Somehow we call this as a neutrally framed invitation letter because it seems that the classical invitation letters in general that are being sent are more or less like, are in this fashion. So in the negatively framed letter, what we actually try to do, we try to frighten the female patient, the patients, and in general, there is quite a big evidence in behavioral econ in general that negatively framed information or negative frame might affect individuals much more than a positive or a neutral frame. And it says the following: please know that scientific studies demonstrate that non-participating in cervical cancer can have negative effects because relatively lately diagnosed disease is increasing the mortality, applying more extensive surgeries, more expensive treatments, so far, so forth. So basically, this was the negatively framed letter. And for concern for other letter, basically what we tried to do, we tried to convince the female, the eligible females, that even if you do not go to screening for yourself, please do it for your beloved ones, because basically they're expecting to live a long and happy life with them. So this frame can activate 2 kind of thinking. So one is this other regarding preferences of individuals. So as a female, I might kind of go I might undertake a screening because I'm thinking about my, for instance, family members, and I want to make them happy. So, and the second reason is that I think is the second mechanism that can be activated is so-called guilt aversion. So my family and friends have specific expectations about myself. So they're expecting me to live a happy life with them. And given this, I want to meet their expectations. And in order to meet their expectations, I have to undertake the screening. So if I don't meet their expectations, then there will be the sense of guilt. And this guilt aversion is quite a motivator of human behavior in behavioral economics. These are basically the letter frames. As I said, the letter is exactly the same in all 3. The letter is exactly the same. The only thing that changes across letters is the frame of the letter. It's this additional information that we provide. So how this assignment to treatment works, and what was the overall timeline of the trial. So we had around 36,000 eligible females in the region of Chirac that were eligible for screening as of February 2019. Okay, so since the screening, it takes place every 3 years. So what we tried to do, we tried to remove all the guys that basically participated in the screening in the previous 3 years. So for instance, those guys from February 2016 to February 2019 were not eligible for the screening any longer because they undertook the screening before. That's why basically we excluded these guys from the sample. And we were planning to we randomized the data of these 36,000 individuals to treatment and control groups as of February 2019. And we were planning to start from March to April, but basically for some reasons the actual start took place in around May. Okay, so we sent the first letters in May 6. Okay, so in general, 28,000 people received letters. So the letters were received 3 weeks before the scheduled week of the screening. So in the letter, we're saying the following: please go to your general practitioner from March 3 to March 10, for instance, okay? So given this, the letter was received 3 weeks before March 3, okay? So 3 weeks before the scheduled week. And if there was a reminder treatment 1 week before the scheduled week of the screening, there was also a reminder received, okay, by the females. This is basically how it worked. And those individuals, as I said, that did not receive the letter or reminder were kept as a control group, okay? So we had around, so in Armenia, every eligible female is attached to a specific GP, a general practitioner, and these general practitioners are sitting in different hospitals, okay? So we worked with 10 different primary care units in the region of Chirac, and there were 80 general practitioners in these primary care units in the Chirac hospitals, okay? So what we did is the following. So each, as I said, each GP had a share of population attached to her. So imagine there were like 10,000 patients attached to a specific GP, okay? So on this 10,000 females were 1/3 of the overall population, okay? So we made sure that in the sample that we are working with, in this 20,800 individuals, again, this GP has as many patients as in the general population. And these females that were attached to each GP were randomized into either a control group or to a treatment group, okay? In other words, each GP had individuals both in the treatment groups and in the control groups, okay? And this was done for each 80 GPs, okay? So first of all, we randomized the patients to different treatments, and then we also randomized which patient is going to get the date of the delivery, okay? For instance, patient 1 was randomized to get the letter in week 1, patient 2 was randomly allocated to week 3, patient 4 was randomly allocated to week 5, because we did not send all the letters at once, okay? For instance, we sent a certain amount of letters in week 1, a certain amount of letters week 2, a certain amount of letters in week 3, okay? Is it clear so far what I was explaining?
Well, I think, yeah, it is. So far.
One of the problems that could happen because of this individual level randomization is spillovers. So for instance, it could be the case that I got an invitation letter which is negatively framed, and my patient, for instance, and my neighbor did not get any letter. We would just speak to each other, and basically, given this, I would take this guy who did not get any letter with me to screening, but this we could not really control because of the randomization strategy that we opted for. But in general, since the participation in the control group that did not receive any letters was very low, we think that spillovers are not really much of a big problem in our experiment. So this is the overall structure of the experiment. As I said, we had 20,800 individuals randomized into 8 different treatments. So in the negatively framed arm, so individuals received a negatively framed, 2,600 individuals received only a negatively framed letter. 2,600 individuals received a negatively framed letter and a negatively framed reminder. So the same for concerns for others. 2,600 people received only a letter with a concern for other frame, and another 2,600 individuals received both a letter and a reminder, okay? And the reminder was also negatively framed. And in the neutral letter arm, there were individuals that received only the neutral letter and no reminder. There were individuals that received a neutral letter and a negatively framed reminder. There were individuals who received neutral letter and a neutral reminder, and there were individuals who received a neutral letter and concern for other reminder. In other words, we tried all possible combinations with the neutral letter arm. Okay, as you can see, there are different invitation strategies. Now we have around 8 different invitation strategies, either a letter or a letter and a reminder, and both the letter and the reminder can have different frames. Okay, and we try to see basically which one works better. And as I said, there were around 15,000 individuals who did not receive any letter and any reminder, and those guys were kept as a control. Okay, so we implemented the RCD from May to July in the Chirac province.
Armen.
Yeah.
Armen. Yes, sorry, a quick question.
Sure.
I do not understand what is the reason why you do have different letters only when you have the neutral setting, while so you have all the 4 different remind in the last case, but not in the previous 2.
I see. Yeah. First of all, we could not really try all because it could be a problem of sample size and spillovers. If you would have too many treatments, then we would definitely increase the risk of having spillovers in our sample, and also there would be a risk of having an underpowered trial because of having too many treatments and too few individuals in each treatment. And the second reason that we were discussing was that neutral letter itself is, in our view, much weaker than, for instance, concern for other or negatively framed invitation. That's where we're trying to see if a neutral letter is sent, which is basically the main invitation strategy in many countries. If a neutral letter is sent, then perhaps if we follow this neutral letter with a much stronger frame, wanted to see basically how the participation would change in this case. For instance, if we had a negatively framed invitation letter which is strong enough, and then the negatively framed invitation, for instance, would be followed by a much weaker frame, which would be this neutral frame, then perhaps maybe this might not really make too much sense for us, because we start with a very strong invitation strategy, and then we kind of continue as a follow-up with a much weaker invitation strategy, which were, for instance, would be this neutral letter. Okay.
Thank you very much.
This was our discussion, if I remember correctly, 3 years ago. Okay, so the data we have, first of all, we look at the internal records of the hospital. So this data in general is very hard to get, but since we're working with the Ministry of Health and the government, this was it was given to us. So this internal records of the hospitals basically shows patient by patient whether these individuals participated, undertook the screening or not. Okay. So in other words, if a female got a letter and this female came to the physician and she got and passed the test, this is basically observed in the data. Okay, we know whether an individual got the screening or not. So for the background data, we know the date of birth of the females. We know basically where they live, whether this is a rural or an urban area, and we know which general practitioner they are affiliated with. Okay, and so the take-up is measured from May 6. For the first day we sent the letters until 19th of July 2019. Okay, so in other words, we have the actual screening data, we have the background data, and also where we have post office data. Again, this is individual level data, female by female. So we know whether the letter that we sent was delivered to this female or not. Okay, so if the letter was not delivered, we got a message from the post office that your letter was not delivered. Okay, this we do in order to make sure that we can have also this treatment on the treated estimates. Okay, so this is just a very quick snapshot of the regional data in over time. So you see here in this graph, basically what you see is participation in the cervical cancer screening program in Chirac and in rest of Armenia in 2018 and 2019. Okay, so these 2 lines here indicate the time in which we basically did our experiment. Okay, from May 6 to July. So what we actually can see from this data is that if we look at Chirac, which is this solid black line here in 2019, and if we compare Chirac with the rest of Armenia, which is this solid gray line in 2019, what actually we can see is that the participation in the region during our experiment was the highest in all Armenia. Okay, in other words, we managed with our intervention to boost the participation so much that while Chirac was kind of comparable to the rest of Armenia in 2018, but it was slightly lagging behind. So we managed to increase the participation and make it the highest in Armenia. Okay, in other words, the bottom line of this graph is that females do react to invitation letters and females do react to reminders. And now the idea is to check which invitation letter and reminder work the best. Okay. So this basically, this is already the data within our experiment. So what happened? As you can see, when the control group, so this is the group where there was neither letters nor reminders were received. In this control group, the participation is around 2%. So it's very low. And you can see that once a letter is received, the participation goes up quite a lot. And once the letter is followed by a reminder, then basically the participation goes up even further, okay? So when we try to kind of understand, I mean, you can see that the frame does not really seem to matter that much, because when we do some analysis, we see that basically for invitation letters, the frame does not matter. Also in the same way, if we compare the treatments with that received both a letter and a reminder, again, we see that basically the frame does not really matter much, okay? So what we only see is that letters matter, and on top of the letters, also the reminders matter, okay? So this is first the descriptive evidence, and
Excuse me, Armen, you have a question in the chat from Sergey.
Oh, sorry.
Yeah,
sorry.
It's not terribly a question, but you had a picture where, like, if you go back once.
Okay.
Do I understand correctly that when you were doing your experiment, there was a little bit of growth? I'll know it was a little bit before, right?
Yeah, it was a bit. It started to grow a bit. So that why there was this growth, we don't really know. But you can see that once we stop our experiment, there's this dramatic decline, which kind of
in the rest of Armenia as well, right?
Yes, in the rest of Armenia, it's more or less the same. So it's here.
It's the solid, yeah.
It's
I was thinking about like network effects, like you were doing that in Chirac, and like Tavush people were talking to their relatives from Chirac and going for these tests as well, but there doesn't seem to be that much. And like the timing is wrong, right? If that little peak thing was on the right from your thing, then that would kind of make sense. But yeah, I don't think it's.
I think honestly, knowing the context in Armenia, it seems very unlikely that people in Chirac might really speak too much with their, for instance, relatives in Tavush or elsewhere. I don't really think that this would really boost the participation in the rest of Armenia much, honestly. So this might, of course, there can be something, but I'm not really sure that this would be really strong enough in the rest of Armenia.
No, that's why I didn't want it to like barge in. I just wrote it in the chat. So yeah, don't worry about it. Go ahead.
Okay.
Armenak, you asked me about the 10 minutes reminder, so it goes.
Okay, perfect. Thank you.
Thanks.
I'm almost
Sure.
done. So
Perfect.
this is a more formal econometric analysis to check basically what happened. So we estimated an ordinary least square model where simply our dependent variable is a binary variable which takes the value of 0 if the female did not undertake the screening, and it takes the value of 1 if the female did undertake the screening. So we have this bunch of treatment dummies, and the omitted category is the control group where basically nothing happened. We also take into account that we control for GP fixed effects, okay? So what we find is the following, that if we go to this ITT, this intention to treat estimates, so basically what we see is that compared to the control group, the participation in the letter-only treatments increases by around 7 percentage points, from almost in some treatments up to almost 8 percentage points. Basically, we see that on top of this, if we look at the invitation, if on the reminders and letters, we see that the participation increases by around 1 or 2 percentage points as well. So given that there is given that there was no treatment, no framing effect across this neutral letter, across letter treatments, and there was no framing effect across the reminder and letter treatments, we basically pulled all the data and we distinguished between two kinds of treatments. Those treatments that received the letter only and those treatments that received the letter and a reminder. We see that the reminder on average compared to the control group increases the participation by 7.3 percentage points, and a reminder further increases the participation by around 2.5 percentage points compared to the letter treatments, okay? So we also took into account that not all the letters were delivered, so only 60% of the letters were delivered, and we controlled for this fact in the regressions, and there is this treatment on the treated effect. So we see that if we only focus ourselves on those guys that basically received the invitation letters, and we don't really count too much on those that basically on the letters that were not delivered. So this is basically the instrumental variable approach. We see that the effect size goes even higher. So if a female actually receives the letter, the participation increases by around 12 percentage points, and a female and reminder has a very strong effect. If a female receives both a reminder, actually receives both a reminder and a letter, then the participation is around, increases compared to the control by around 18 percentage points, okay? So what we also did, and this is done for our revise and resubmit, and we're discussing this information today. That's why we don't really have this information on, I don't have this information on the slides. We also tried to check heterogeneity in the data. So for instance, are there heterogeneities? For instance, if females in rural areas receive letters, do they react in the same way, for instance, as females in the urban areas when they receive the letters? And the same way, if, for instance, a female is old and she receives a letter, does she react in the same way as, for instance, a female who will receive a letter and is young? So what we see in the control group is that mainly in the control group, remember the control group are those individuals that did not receive any letter, okay? In the control group, what we see is that mainly younger females from urban areas go to the screening. And what we see actually in the treatment groups, once we start sending the letters, we kind of close this urban-rural gap, okay? So in other words, in the treatment groups, we see that urban people, urban females and rural females become equally likely to visit a screening, which is different from the control group where only the urban females were likely to go to the screening. And also what we see is that there is some sort of an age effect, but it is not really that strong. In other words, if a female above 50 receives the receives a letter, she is more likely to react. In the control group. In the control group, younger people are more likely to go to the screening, but in the treatment group, what we actually see is that both younger and older females become equally likely to visit the screening. Okay, in other words, there is a rural-urban gap in the control group, and our invitation letters and reminders allow us and help us to close this rural-urban gap. Okay. So to conclude, this is the first RCT which tries to, to the best of our knowledge, this is the first RCT that tries to kind of study the impact of invitation letters and reminders on cancer screening participation in the developing world. So we find that there is quite a big impact of letters and reminders on participation in low and middle income countries. Frame does not seem to matter. Invitation letters matter, and they matter even more if they are enforced by reminders afterwards. Okay, so this was our study. If you have questions, please let me know. Sorry if something was unclear. I always find it very hard to present online when I don't see your faces, but that was it. So if you have questions, just let me know. Or if something was unclear, I'll try to explain a bit further.
Thanks very much, Armenak. No, everything was pretty clear, I guess. So, thanks, and we have time for questions, comments, answers. Please, Sergey.
Yeah, I think that was a lot of work, and you know how everybody likes RCTs in our profession. But one thing that I would do would be to put a monetary value on, you know, an additional person participating in a screening. You see, so you gain, I don't know, 10% boost in attendance. How many lives have you saved? Right? Here is the price of our intervention, right? Here is the benefit of our intervention. Here is 100,000% return on the intervention, right? So I guess my point is, what you show is that it's the letter that's important. It's not so much like you can screw it up. It doesn't really matter, right? How exactly you write doesn't matter. As soon as, you know, it's a reminder letter that works, but like put a number on that, put a value on that, put a dollar on that, if you put a drum. Right, cheers.
Well, if I may, I'd like to second what Sergey said. I think you have a great opportunity to measure the effectiveness of screening, because now you have a randomized experiment. And if you can trace medical histories of the patients, of the women that participate in screening, you can instrument screening by invitation letters, and then you will have very reliable estimates of the effectiveness of screening over some period of time. So does it really help to save life, to improve the outcomes of treatment and so on? So I'm not sure if it's possible to follow medical histories of the people that receive these letters, but it might be worth trying. Because so far, what you tried, you did some behavioral economics analysis, but now you can also contribute to the body of knowledge as to how screening helps to prevent.
Yes, thanks for the comments. Honestly, we have thought about both comments, and why we don't really have this in the paper is the complexity of getting data, especially medical data, in a developing country context. Okay, so first of all, we don't really have this. We do not really have the I mean, there is the medical history, but we were not allowed to access the medical history because this is protected both by medical law as well as privacy law in Armenia. It took us, honestly, almost a year and a half to negotiate to run the RCT, and another 1 year to run and analyze and write the papers. So the preparatory work was much tougher than implementing the RCT and analyzing the data itself. So that's why we don't really have this information, how many lives we saved, and given this, we cannot also do cost-benefit analysis in the sense that there are no estimates about cost of life in Armenia, and in developing countries, we looked for this information a lot. So for instance, we don't really know what is the value of an additional year of work, for instance, of an Armenian citizen or of a citizen in a developing world, so that we could be able to do cost-benefit analysis, trying to understand whether what we did in monetary terms is kind of beneficial or not. Okay, so we tried a lot, we looked for a lot of data and sources, but honestly, this was not possible to achieve. That's why we don't really have this cost-benefit analysis specifically implemented in the paper. Okay.
Yeah, thanks, Armenak.
I hope I answered.
Yeah, there are more questions, and in the order they received. Maria, please.
Thank you, Armenak, for a very interesting and inspiring presentation. Everything was clear. I just have a comment and a question. My first comment would be about network effects and spillovers. I still didn't get your comment on the importance of social ties. So, for example, I'm in a treatment group, and the member from my household is in control group. So I influence her by my personal record. And also, what is important about societies with low incomes is that social ties are particularly important there, much more important than formal institutions. So in this kind of environment, it's much more important than what people tell each other. And if I tell you that I was visiting doctor and it was very nice and everything, that would influence you a lot. In addition to the letter, that's my first question and concern. And my second question is that the job status is important. So if I have a job, it might influence me in different ways. First, I might have a problem in negotiating with my employer of going to the screening in the weekday. And I might be a little bit ashamed to approach him saying that I need to go to doctor and explaining him what's going on. Because I don't want to look unhealthy in his eyes. That might be first problem. And another aspect is that if I have a job, I don't want to lose it. So I would like to stay as healthy as possible to be able to earn money for the family. So there might be different kinds of influence here. So did you look on the job status, and if yes, what were the results? Thank you.
Okay, thank you for the questions and comments. Let me start from the end. So as I said, we have the following data. So internal records, whether someone went to screening or not, date of birth, place of residence, and general practitioner ID. Okay, so unfortunately we don't have the job seeker job status, so whether a female is employed or not, and that's why we cannot control for different socio-economic and socio-demographic characteristics of the females in the sample. But let me just try to kind of defend our position. So given that we run a randomized control trial, this means that we randomly allocate females to different treatments. And in my view, this means that this issue of work status or like employability equally applies to females in almost all the treatments, okay? So because we randomly allocate the females to different treatments, in my view, it is quite unlikely that, for instance, all the females that had job and job-related problems accumulated in the control treatment, and all the females that did not care about their job or were unemployed were kind of accumulated in the other treatments, okay? So randomization ideally should allow us to solve this problem and should allow to kind of distribute this kind of females and this kind of concerns equally across all the treatments. Of course, this is to be 100% sure of what I'm saying. We should have the employment status and make sure that these treatments are balanced in terms of employment or in terms of employment concerns if this data exists. But since this data does not exist, this is just an educated guess based on the logic of the randomization. So in other words, the concerns of employability and the concerns of job and everything or employment should ideally apply to almost all the treatments that we have. And if this is the case, then this issue cancels out from our analysis, okay? So this is my comment to your first question. Your second question, regarding the spillovers, what we actually see is that in the control group, the participation is very low, okay? In other words, if, for instance, the spillover would be a concern, in other words, those who receive a letter would kind of go to speak to those who did not receive a letter and would kind of push those guys to go with them to the screening, what we would see in the control group is high participation rate as well. Okay, in other words, if there is a spillover, those guys who go to the screening in these treatments would affect the control group, and this would mean that the screening rate in the control group should be higher as well. Okay, in other words, the participation in the control group should be close at least to the participation in the latter treatments. Okay, in this case, we would suspect that there is some sort of a spillover effect because those in these treatment groups kind of affect the participation in the control groups. But we see a dramatic gap between those who don't receive a letter and those who receive a letter or a letter and a reminder, which kind of seems to suggest that there are not really much spillovers or in the RCT. Okay, did I manage to explain my position?
Yeah.
Very good. Paola has a question, please.
So Armen, thank you very much for the presentation and for, sorry to be late, but I had a meeting. And I have a couple of questions or maybe curiosity. If I understood well, you do have in your data where this woman live. So could you have a measure about the distance from the place where they have the medical test? This could be relevant because somehow it could be a proxy for a sort of, let's say, cost of having this exam. And this is the first. The second is that if I understood the point about the information you have from the hospital, you do have some information about the familiarity in disease. Do you exploit this familiarity? Because this could be really an interesting point to see what is the effect on people that, so the effect of these letters on people that somehow are in a process of, disease, and so all, this attention to what they should do. They are already in this process, and instead the effect on people that is not in such a kind of process. Thank you very much.
Okay, thank you. So regarding the distance, the distance actually seems to be an important variable in Marco's and Luca's paper about screening in Italy. And we, of course, also wanted to have this distance measure in our paper. In other words, we wanted to measure the distance, as you said, from the address where the individual is living to the hospital or to the primary care unit where this person had to undertake the screening, okay? So ideally, since both the address of the individual and the address of the hospital were known, there should not be any problem in computing the distances, okay, in the modern world. This would not be a problem in Italy. I think this would not be a problem in France, but this is really a big problem in Armenia, where especially in the rural areas and in the villages, the addresses are either not well written or the addresses are not in Google at all, okay? So given this, we cannot really use any online, like, any statistical software, for instance, InSt Data, or any kind of software to extract the information from Google, more specifically from Google Maps, and compute the difference between the coordinates where the guy is living and the coordinates of the hospital, okay? In other words, the addresses were there, but they were not in Google Maps, they were not in a good shape for online usage, and that's why we could not really compute all the addresses of the females. That's why we don't really have this variable in the regressions, okay? In a nutshell, we tried to get it, we could not. Regarding the familiarity in disease, actually, I'm not sure we have this data. We have this variable. And which slide did you get this impression from?
Hola.
Yes, where you presented something about GP fix effect. There was a slide about GP fix effect before. No, before. Maybe here? No, in the next, sorry. Next? Yes, here, each letter, no. Okay, but maybe I'm wrong, so.
Honestly, we don't have this. It would be an interesting, actually, proxy, an interesting variable to throw it into the regression as a control. But no, we don't have any variable that could proxy the familiarity with the disease, and that's why I'm not sure we can work with this data and the variable.
Sorry for my misunderstanding. Thank you.
Yeah, no problem. I'm sorry.
Okay. Well, thanks very much. Let's see if there are any other questions or comments, concluding comments. Anyone, please? All right. Well, I don't see any. So, Armina, thanks very much once again for a very insightful presentation. Be safe and good luck with your work, and hopefully we'll have a chance to meet and talk again.
Okay.
Sergey, there are questions, guys. I'm sorry. Let me see.
That's a clapping. That's a clapping.
It's a clapping. All right. Okay.
Yes.
All right. I didn't get it right away. Okay. Well,
yeah,
thanks.
May I ask just a short question?
All right. Of course.
Yeah. Do you have any idea to continue this research? And if yes, what are your plans to further clarifications? Do you have any big ideas in mind on this topic?
Okay, so at the moment, the government wants us to work in a breast cancer screening program, but this project is disrupted because of COVID-19 for the moment, and because of this strange situation on our border between Armenia and Azerbaijan. So given this, at the moment, this project is stopped, but ideally we were supposed, and hopefully we will, work in breast cancer screening. And we were thinking about something similar to what we did here, also to implement, for instance, in breast screening program and add something more to the framework. That's basically my idea. I mean, if you have, for instance, connections in Russia, I might be interested in kind of doing such kind of stuff also, for instance, in Russia, either, for instance, with our team. And actually the study was funded by the Russian government. It's called UNDP, Russia Trust Fund. So that's basically it. So I mean, at the moment, I'm working in this direction in Armenia, but I can also extend to other regions and countries. So this is the overall setting for the moment.
Excellent. And certainly we are very pleased that Russian support was used in this important work. Good job. Bernardo, can you please remind us what's coming up next, as always? Who is the next speaker?
So next Thursday, we have John Bray. He's a job market candidate from the University of Nottingham. And he will be presenting his job market paper titled "The Long Run Gains from the Early Adoption of Electricity." So we're moving a bit more to economic history.
Excellent.
So next Thursday, same time, same place. So hope to see you all here. And well, I joined the thank you, Armenak, for your presentation. It was great to have you here online, and hope to meet you at some point in the future in person in Armenia or in Russia.
Okay.
Thank you very much
Armenia,
for listening. It was my pleasure to present. In fact, I was in Russia a few months ago, but given the COVID situation, I didn't show up too much in the department. That's why perhaps you haven't seen me. Thank you.
Thank you very much. Have a good night, everyone. Be safe. See each other again in a week. Bye-bye.